masquerade syndrome are disorders that occur with intraocular inflammation and are often misdiagnosed as a chronic idiopathic uveitis. So the patient presented mainly with idiopathic bad uveitis, but the true diagnosis is not uveitis. The term masquerade syndrome, first used in 1967, described a case of conjunctival carcinoma, which was diagnosed as chronic conjunctivitis. This is the first term of the masquerade syndrome. This case was reported as chronic conjunctival inflammation, but it was conjunctival carcinoma. Early diagnosis and the proper treatment are critical in this case, because you will find most of these cases have a poor prognosis if you diagnose this case late. Malignant disorder, masquerade syndrome, masquerading as uveitis, intraocular lymphoma, carcinoma, metastatic to the eye, cancer-associated retinopathy, bilateral diffuse uveal melanocyte proliferation, childhood carcinoma, or retinoblastoma, leukemia, hidradenocarcinoma. All of these are malignancy. Looks like uveitis and presenting in one of its presenting symptoms and signs. Non-malignant ocular disorder masquerading as uveitis, intraocular foreign body, long-standing, retinal detachment, also long-standing, myopic degeneration, pigment dispersion syndrome, intraocular infection, drug reaction, post-vaccination, and finally retinal degeneration like retinitis pigmentosa. The most important thing is that intraocular lymphoma as the first susceptible case of the masquerade syndrome in old age patients. Primary intraocular lymphoma involves the retina, the vitreous, optic nerve health, or with or without CNS involvement. Most primary intraocular lymphoma are diffuse large B-cell lymphoma, as this case was presented by Dr. Waida yesterday. But you should know these incidents. 15 to 25% of patients with primary CNS lymphoma would develop ocular manifestation or intraocular lymphoma. So if you have a patient with systemic CNS lymphoma, 25% of them will have intraocular lymphoma during the course of their disease. Okay? But if you diagnose your case as a primary intraocular lymphoma, 90%, up to 90% of them will have CNS lymphoma. This is why our treatment in primary intraocular lymphoma, including systemic immunosuppressants, amitriptyline. Yeah, because 90% he will have CNS. I will not wait. We'll have this scenario in the next case. We published this case 2011 in American Academic Journal. It was 57 years old, immunocompetent woman, had 1 month history of blurry vision and flutter, more in the right eye. This was in her hometown country. It wasn't in the United States. 5 months later, deterioration of vision increased with more flutter. Serology study show elevated C3 and ESR, thus means non-specific inflammation. Positive for toxoplasma IgG, okay, thus means it could be chronic, but also cytomegalovirus IgG could be chronic. So, diagnostic vitrectomy was done by the fellow Dr. Foster there for the right eye. The specimen show positive for monoclonality with IgH change, gene rearrangement by PCR analysis. This is one of the highly advanced technology studies which help in diagnosis of intraocular lymphoma, but it's one of, not a diagnostic sign only. So, also the PCR show toxoplasma gondii DNA also in the vitreous. So we have maybe intraocular lymphoma, but we didn't find any lymphocyte cells inside the vitreous. And we find toxoplasma. So you have infectious in type, and also you will have intraocular lymphoma. Which one you will treat? They start to treat the infectious. As this is the gold standard rule, you should treat the infectious gold number 1. Intraocular lymphoma will not kill the patient, but if you start treatment with methotrexate, you will deteriorate the intraocular toxoplasmosis. Okay? So they start triple therapy for this patient. With the treatment, there is no improvement, and the continuous vision deteriorated and more floated. This fellow sent this case to Dr. Foster. We examined her case at Mercy, Massachusetts Eye Research Institute. We found her vision 20/80 in the right eye, 20/50 in the left eye. The anterior chamber was free of inflammation. There was 2.5 vitreous cells in the left eye. Usually you will find these patients also in grade 4 disease. Why you will find mostly the chronic cases, the anterior chamber is free of inflammation. This is the color fundus and fluorescein of this case. You will find the left eye photo. The haziness is too much, maybe +3, but you can see the disc and the vessels. The other eye, this looks like normal, but still some +1 haze. If you look to the fluorescein in the left eye, you find in all of present there is hyperfluorescent spots, including the whole posterior tube, especially the superior temporal artery. With fluorescein, late it will be hyperfluorescence. Late it will be hyperfluorescence. So, we could also put 2 differential diagnoses for this case. Bilateral diffuse uveal melanocytic proliferation, or bilateral thumb syndrome, or intraocular lymphoma. I will talk a little bit about Down syndrome because it's a strange disease, even to me, and I had to read about it to know this disease. There is 5 counter signs related to this disease. It should be multiple red patches at the level of the retinal pigment epithelium, corresponding by hyperfluorescence patch lately. Develop multiple pigment and non-pigment uveal melanocytic tumors with diffuse thickening of the uveal tract, exudative retinal detachment, rapidly progressive cataract formation. This is one of the rare cases of Down syndrome, which most disease cases are bilateral, but this case was published by one of the doctors in, I think, Spain, New York. He presented this case with unilateral syndrome. It's not bilateral. With choroidal thickening, choroidal fusion, this hyperfluorescence. But our case is not the full criteria for this. So, Dr. Foster repeated the vitrectomy again to the left eye. Also, he didn't find lymphocyte cells, which is the most important sign for intraocular lymphoma. Once you find lymphocyte cells inside the vitreous, this is intraocular lymphoma. But also we found the monoclonality of the cell population with PCR, IgH, gene rearrangement also was positive, like the same result which the patient had in his own country. There is another parameter that is very important in diagnosis of intraocular lymphoma is interleukin level 10 and 6, interleukin 10 and 6 ratio. If this ratio is disturbed up to 10-fold, it will be diagnostic sign. But we still haven't this result yet. So, there is absence of histological goal. We did for the patient brain MRI. It was free. Chest tomography. There is pulmonary review. So there is a new differential diagnosis. You would think in sarcoidosis or something we don't know. Bronchoalveolar lavage confirmed the presence of Aspergillus and Streptococcus infection. But there is no periodontal inflammation which will exclude sarcoidosis. Also, the lung biopsy was negative for any malignancy. So our lesion only in the eye, but till now we don't know which one is it, inflammatory or malignancy. So we have also the same problem like the fellow in this country. Dr. Foster decided to start immunosuppressive treatment because he facing vision-threatening condition, progressive bilateral ocular inflammatory infiltrate with pulmonary function. Or he will proceed as a diagnostic intraocular lymphoma. He had a consultation from Dr. Bakur in Mass General Hospital, and the result of interleukin 10 and 6 ratio was tenfold. So they stopped the cyclosporin azacitidine after 2 weeks because there is no improvement also. And they diagnosed this case without lymphocyte cells in the vitreous as primary intraocular lymphoma. They start to treat the patient with methotrexate, with 2 route, intravitreal methotrexate injection, and intravenous methotrexate. The condition of the patient improved, and we sent the patient to his home to continue his medication. But the story not yet finished in his country. The neuro-oncologist refused to give the patient systemic methotrexate. They have a system there. You cannot take your medication without a prescription from the doctor. So they refused to give this lady the methotrexate infusion, and the ophthalmology doctor continued to follow with intravitreal methotrexate injection only. And they told the doctor there, if there is no lymphocyte, this is not intraocular lymphoma. This is inflammatory eye disease only. Will not give the patient systemic methotrexate. So 12 months later, the patient developed dysarthria and dysgraphia, CNS manifestation. And they did MRI there, and you can see here these white lesions. They didn't believe themselves. They sent this for biopsy, for the neurosurgery. It was diagnosed as CNS lymphoma. So this patient presented with uveitis. Even before the full criteria of intraocular lymphoma, we suspect, because we had the main idea about the masquerade syndrome and could be presented early with uveitis, than uveitis, and there is no lymphocyte cells, but the diagnosis now prove it with the biopsy. You see the scenario is totally different now. We will treat the patient with full aggressive CNS lymphoma with methotrexate, and we continue methotrexate intravitreal. Monthly infusion intravenous given, 8 grams, provided for 8 cycles over 6 months. Also rituximab for 4 cycles. total 20 intravitreal methotrexate injection in each eye. In her last examination, 38 months after the primary presenting symptoms of closure, the patient was mobile, speaking fluently, coherently, with no obvious neurological defect, completely cured. Her visual acuity was 20/30, 20/20, no infiltrate, restriction required, everything is okay. So if you treat your patient with primary intraocular lymphoma yearly, you will save all of these dilemmas we are talking about. But we published this paper for one point, that they should change the parameter to accept primary intraocular lymphoma as a disease could be diagnosed by the new technique criteria. IGH change with interleukin 10 and 6 ratio. It will be enough as early sign accepted for primary intraocular lymphoma. The second case, 30-year-old man with a history of night blindness, decreased vision in both eyes. They diagnosed him in multiple areas in the United States with resistant case of idiopathic uveitis. The past medical history was there is a history of optic neuritis, history of vitrectomy in his left eye. Laboratory analysis for the vitreous was unremarkable. The past treatment for this patient was methotrexate, chlorambucil, microfluoride fatigue, cyclophosphamide, cyclosporine. So he took in the past history all the immunosuppressive medication, and he still have the drugs. He still have very vision. So on examination 2015-2016, the anterior segment examination saw fuchs endothelial corneal dystrophy with anterior chamber plus 2 cells, flare in both eyes. There was mild posterior subcapsular cataract in both eyes. This is why his vision 2015-2016 we think. This is a photo for the patient. Posterior segment examination, vitreous cells plus 2, perivascular retinal pigment epithelial change, pupil edema in both eyes with splinter movement in the left eye, but you cannot see it here because this is, I think, photo after treatment in our clinic. This is 50 milligram intravenous every week. Treatment pulsed intravenous methotrexate 50 milligram every week was started. His visual acuity improved to 20/40, not too much from 20/50, 20/50 from 20/60. Inflammation improved to +1 cells, not 3, in the right eye, and trace cells in the left eye. Trace cells mean less than 5, 3 to 5. We call it 0.5 plus or less. Methotrexate infusion was stopped when inflammation was acquired. No evidence of vasculitis in the fluorescein as we saw it. Later, the patient went to cataract extraction because we found there is a posterior subcapsular in both eyes. Maybe he will improve to 20/20. But after surgery, the patient continued to have 20/30, 20/40 in the left eye. He was starting to show mild macular edema in the right eye with central retinal thickness 379 mild in this eye, and the other eye there is atrophy for the macular thickness. It was 170 micron. So we still have a problem with and the patient continued complaining of blurry vision, global night blindness. The patient left us and he didn't continue with the foster and looked for another institute. Later on, we called this patient and to see what's going on with him. He went to the National Institute of Health in New York and they examined him again and they looked for one thing, history. They asked the primary care doctor in his own city to to send for him all the medical family history for all his family members. They discovered that his father was retinoid pigmentosa. He was died at that time. They did for him ERG for the retina, and they diagnosed this case. This is the ERG, it's different than our ERG. And they diagnosed it as atypical retinoid pigmentosa, one of the differential diagnoses. And I saw the chapter of masquerade syndrome was written by Dr. Foster, and one of the possibilities is retinoid pigmentosa, and he missed this case because the assistant at that time didn't ask about the history, the family history of other ocular diseases. So there is no one can give 100% full diagnosis with anyone, but you should be classical. And he asked for the file, and asked who the doctor asked the patient about this. This patient was, I think, about 20 years before I was there. But we start to publish this case as the first case of retinoid pigmentosa associated with Uveitis Ocular, because we found in the splinter hemorrhage and vessels that this case could be one of a rare case of atypical retinoid pigmentosa presented as a masquerade syndrome because the rapid degeneration in the rod and cones presented with this reaction, or could be associated atypical retinoid pigmentosa associated with Hispanic vein. We cannot say one of these. No one can diagnose 100%. As the story tried, the uveitis, the masquerade syndrome tried to inform you I am uveitis, but in the real thing it's not. Okay? Thank you.